Yeah.
Yeah.
So I guess we're ready to start. So welcome back, everyone. And just before we start, it's probably worth mentioning that I can see people have responded to the Mentimeter. Really good to see that. Please, if you haven't responded, continue to do so. The link is in the chat. And for now, for the next session, I'll pass on to Kevin Sprague and David Crampin, who are here to talk about UK Core, and they will give you an update on the roadmap for the next release, but also talk about the relationship between Digital Meds and UK Core. So over to you guys.
Yeah, good. Thanks, Daniel. Yeah, hi everybody. I'm Dave Crampin. I'm the fire product owner at NHS Digital, and I also manage the interoperability standards team. So I'm presenting with Kevin Sprague, who's a senior technical lead in our team, and responsible for a lot of the development of the UK Core. I'll just briefly say, so I don't know if everyone's familiar with the UK Core, but Kevin will cover a lot of the background, so I won't go into that just now, and certainly welcome any questions towards the end. But we're also planning separate Learnathon and Hackathon. We were intending initially to do them this year, following on from the Meds one, but having seen the amount of time, effort and prep that's gone into these, I think we'll be doing ours early in the new year, but we'll share those dates, and I'd certainly welcome everybody to come join the Learnathon, because we really want the kind of participation and involvement about the topics we're going to cover. So it'll be our first Learnathon and Hackathon, but I think hopefully a very beneficial one. So with that, I'll hand over to Kevin, and as I say, if it's okay, we'll take questions at the end. Thank you.
Okay, thank you, Dave. Hopefully everybody can see the screen okay. So just to give you a quick update of what we've been doing in the core, and for those that don't know what the core is, and potentially what it isn't. We do have a vision, and we've had a vision for a long time, and that's about creating interoperability across the 4 nations, using a sort of fire sort of idea, which is cores. So there's a US core and an Australian core, so we're looking at created a UK core, and this is about enabling us to flow information across countries, so for cross-border exchanges, but also in a consistent way, with obviously the benefits that you get from having multiple countries, multiple resources, multiple inputs, and potentially a much better solution. So what is the core? It's an approach based on Care Connect, but building on the lessons learned. So Care Connect was very English-centric. It was only really scoped for England. We know for a fact that when we spoke to people in Wales, they said, well, we can't use Care Connect. It doesn't actually doesn't really cover what we do in Wales. It's in effect constrained us out. So the UK core is totally different. We are looking at a UK-wide scope, i.e. the 4 nations. We are engaging quite strongly with Wales, and we have regular meetings with them. We are engaging with the other 2 nations, but at a lesser extent, I think mainly because they're not as mature in their fire work as we are in England and Wales. So the core is basically a set of fire assets, trade and profitability across the UK. So when we say assets, we're talking about things like fire profiles, value sets, code systems, and extensions to the fire standard. So it is developed by a central team. The team mainly consists of actually NHS Digital IOPS team at the moment, in partnership with HSM UK. So we don't own it; it's owned by HSM UK, and we are the development team working with them. We do welcome other people, so although it's only currently being developed by NHS Digital, that's not the dream or the what we really want to do. What we want to do is open up to a wider group of people to sort of engage and help develop the UK core. What it's not, well, it's not the answer to interoperability. No matter how hard you push that, a technical solution is not ever going to be the answer. It's a key component to help get interoperability across the UK, but it's a much more complicated beast than just getting a set of technical assets and saying, "Oh, implement them, job's done." It requires a lot of collaboration. It also requires things to change in systems to align all the systems, and many other things need to change, and collaboration across various things to make this happen. And just to reiterate, it's not the centre dictating, so it's not any just digital saying this is how you do interoperability. It's about creating a collaborative solution for interoperability with anybody who wants to get involved across the whole of the UK. So progress to date, content produced. So we've currently got 43 profiles in the UK core, 30 of those are active. And when I say active, these means they have been assured either by HL7 UK ballot or a clinical and technical assurance process that is applied to fire assets in a series of sprints. And I'll go on a bit more about that later. We still have 13 draft profiles. So draft profiles are ones we create, people who want to do early engagement and first types using UK core. We create a set of draft profiles just so they can take their first types through. But obviously they do that with the understanding that because they're draft, they may change when they get balloted or assured with clinical and technical assurance. But it's really good to get people engaging early on to sort of shape the core using real use cases. And likewise with extensions, we currently have 39 extensions to the fire standard. 38 of them are active, i.e. they've been assured and balloted and agreed for that they're sensible and useful across the UK. And there's a draft extension has been created just for a first type to do some work, and that will all feed into the clinical and technical assurance process and the ballot at a later date. What assurance has had so far? So it has had 5 sprints of clinical and technical assurance, and they have been completed. So we've got ticking a box from a fairly large group of people. It's had 1 HL7 UK ballot completed. The ballot process is very nearly to the end. We're now undertaking the development associated with that ballot. So we had quite a lot of comments. We had around 500 comments back. They range from a simple typo to something quite a lot more complicated, like why does this not follow the US core, or this value set doesn't work for us, and things like that. But everybody in the UK has the ability to become part of that ballot process. The UK also is now a fundamental standard for England. So that basically means that it's similar to SNOMED in that the DAPB board have actually approved it, not on the actual content, so they don't look at the profiles of value sets, but they look on the processes around producing the content. So things like, is stuff reviewed properly, does it have the right engagement, and so forth. So a bit more detail about the clinical and technical sprints. So there's been 5 to date. Sprint 1 was really what we called the fundamental profiles. So they were things like patient, practitioner, organization, location, things you need every day before you can even think about doing the clinical information. The second one was all around allergy intolerance. And the third was then when we worked with the DigiMeds team to do the medication resources, so the various medication dispense and administration type things, and also the immunization. Those 3 sprints that are in white are actually have gone through the ballot, and they're the ones that we were even in the next release of the balloted content. We then moved on to sprint 4, which had more more fundamental ones that we had in Care Connect, just sort of in effect starting to fill in some of the gaps that we needed. So things like composition, so we could do fire documents, message header, so we could do some fire messaging, and things like list and related person, which were really needed to complete the package and make it more useful. Sprint 5 is really all around booking and referrals. So it had appointment, service request, and various other bits associated with booking appointments. Those 2 sprints currently have been through clinical and technical assurance and passed, but what they haven't been is through UK core ballot, and we're proposing those to go into the next UK ballot, which we're currently calling ballot 2. So a bit more about versions of the core. So for each sprint, we produce a version which goes out is sort of a version that's locked down so that people can review and do the clinical and technical assurance on a point in time version of the fire UK core, so it doesn't actually get changed as we're in the middle of that process. We produced 010, which was in effect the first 3 sprints, then with a version that was in lockdown for the ballot. We then created a series of versions, candidates for the sprint, and then updated versions following the sprint. And the ones in yellow are now is the first ballot version we're working on, which is 100. So that'll be the first sort of fire set of assets that's ever been sort of balloted by HSM UK. And once we've done that, we'll then look on moving on to the second one, so which will be 110, which will include everything to date. And then that will eventually, once it's been for a ballot, become 2.00, which will be the second ballot version, and that will align everything that we're currently doing with between the ballot and the clinical and technical assurance to give us a baseline to move forward on. So the current focus, as I previously said, it's about this what we're calling a technical sprint, and that's about aligning the clinical and technical assurance sprints, which are a lot more lightweight than the ballot process, and therefore tend to move a lot faster. So the timescales are different. So we paused really and said, let's just get everything aligned, to get everything balloted, get everything clinically and technically assured, and then we'll get a much better assured UK core ready for people to implement. So it's just to reiterate, ballot 1 consisted of content from 1 to 3. Ballot 2 will focus on 4 and 5, but it will contain all of the sprints. So in effect, stuff does get balloted more than once. It's an iterative cycle. There will be some changes for the technical sprint, some stuff that DigiMeds have done, for instance, and want included in the course. So some new additions, some bug fixes, which weren't found as part of the ballot or may have occurred after the ballot was closed. Our future focus. So sprint 6 of clinical and technical assurance. So that content is to be defined by the UK Fire Board. Development timelines are dependent on this technical sprint being completed, because until we finish the technical sprint, we don't have a solid baseline to start sprint 6 on. Some of the work could be done in parallel, but we need careful planning and resource availability to do that. It would mean potentially slowing up the completion of the ballot version to do some sprint 6 work. The Fire Board is also to consider a end-to-end process and implementation support for the UK course. So that's more future stuff we want to do. So engagement. So we engage with people to produce draft profiles and assets as required. So to date, most of the requirements have come from either ourselves, NHS Digital, or our programs, national programs that we're implementing, because they're all UK core R4 based going forward. Some input from Wales as well, because Wales are, so they're now part of the using the UK core. We're supporting and learning from early implementations. So anybody who's starting to do the UK core, so we know NHS Digital's done some early implementations. We're trying to learn and support them, but also we're learning and supporting other people who are starting to take up the UK core. Open discussion and agreement of what is required to aid the implementation. So it's not all about creating technical assets like profiles and value sets. We're well aware that there's other things that people might need that we can facilitate to help them. And that's an open conversation. We are doing, as Dave said, Interoperable UK Core Learnathon Hackathon, and there's a bit more about that later. And we're also going to be supporting the emerging interoperability strategy and where the core aligns with that strategy. A little bit really about how to engage with us. So one thing, the simple way is you can email us. We have a team mailbox, which is the IOPS mailbox, but the development team is IOPS, so we take all the anything input from the core on there. You can contact the HSM UK affiliate, HSM UK, and their email address is there on that link. Chat in the UK core forum in River. There's a forum in River which you can sign up to, and we're trying to now look at how best to facilitate that. We've been asked by Interoperable if we'd like to take over that forum for the UK core, and we've readily agreed, and now looking at best to do that and how to make sure people who respond or ask questions in there get a timely response. You can subscribe to HSM UK News in Simplifier. So if you go into Simplifier on that link, it will take to HSM UK's organisation. We do send news items in that Simplifier, and you can get you can subscribe to it, clicking a button in Simplifier, and it will then send you a mail, which you can have once a month, or you can tweak the settings to have it every day if you want to. You can, able to fine tune the amount of information you want to see, so it isn't a burden to your inbox, and we all should know about that. You can then also raise an issue in Simplifier, so you can go to Simplifier on that link and say, can I create a new issue? Your new issue could be a question, or could be that you found something that doesn't work for you in the core and you want something changed potentially, so you can propose an issue change if you want to. Just a little bit now about UK Core and DigiMeds. So the UK Core refers to the implementation guide for digital meds. It has all the fire assets used for that. It supports the ISN, so it's been sort of developed and the guidance has been added to try and make that easier. And the medication allergies, clinical concepts are specified in the UK Core. So, how you do allergies is now part of the UK Core. A bit more about how to learn about the UK Core. So we're going to follow the DigiMeds hackathons and so forth, and this will be in the new year. We were going to hope to do it this year, but we basically ran out of time with things being a bit delayed, and we did want to follow the digital meds ones rather than jump in halfway through. So there are going to be a webinar, a Learnathon, some hack days, and with the actual dates will be to be announced, but we're currently working on how and when that would come together. So just some projected timelines, and these aren't sort of written in stone because it's quite a big piece of work to do. But we're currently working on developing 1.0.0, and we anticipate that will be finished at mid-October. So when it's finished in mid-October, we do a pre-release of that for anybody who wants to say, I raised an issue in the ballot, and I want to check that you've fixed it as you said you would, or whether, and so forth. It is anticipated that no one will go through the whole of the UK Core and check all 500 issues that have been fixed. That's done as part of our sort of ongoing working with HL7. It's a case of us really just doing it on trust, for want of a better word, because it's such a massive task for someone to take weeks and weeks off their time to check it. We will do some internal QA processes, so we will go through a random selection of bugs to make sure they're fixed, and the team are very aware of the need to fix things as the ballot decided, and not to in effect fix things that weren't decided in the ballot or in a way that contradict what the ballot requested. So the working to 1.1.0, which is in effect the ballot to candidate, we aim to start that mid-October, and then release something around the end of November. I say around because what we don't know to date is exactly what the ask is, how many people and the bug fixes or additional guidance from DigiMeds, etc. So we're now looking at what would be in 1.1.0, what fixes we've been doing. The team knows that they have to merge everything that was in clinical and technical assurance sprint 4 and 5, but there's also some additional fixes which are coming into this technical sprint, and that's today is the unknown quantity, but we have some BAs on that now looking to see what can be included. So if there's anything in the medication arena that is pressing, now's the time to sort of let us know. We'll talk to the DigiMeds team so we can try and get that included. Once it's been done, we'll send it for review for 2 weeks like we normally do. We will do any rework that needs doing. That's just, anything that anybody finds or reports back to us, and then we hope, and so this has not been agreed with HL7 UK yet, we're still in discussions. We hope sometime around January to February to then sort of look at doing the second ballot. So projected timelines to 2, which is the fully balloted version. So we would develop it in March. That's based on the feedback from the second ballot. We'd do a pre-release again and potentially some rework in April. And the current wish or desire is to get released to a fully balloted UK Core by the end of April. Just the roadmap to 2, that's really all 3 diagrams overlapping, just to show we are going to do some overlap in them. but that's just an indication of the where it all fits together in a long roadmap. Sprint 6 may interject somewhere in there, and it doesn't have to wait to April. It can be introduced wherever we see fit, and we would be in discussion with various bodies, including the Fire Board, about where Sprint 6 fits and what the content is. Just some useful links. So if you want to find out about UK core versions, the actual versions, you can actually pull that link and it gives you a version history of all the versions, and you can then click on links to take you to each of the various versions. We do have a guide which has been through the DAPB submission, which is how we do the course, so the sort of development processes, how we engage, how we things like conformance to the UK core, how that would be judged, how extensions are developed, and sort of validation stuff, and so, or just loads of stuff really, just to give people a background on what we do, so they can understand the sort of complexities, or if they need to engage the way we plan to do it. And that development process will evolve. It's not a set in stone. It's would develop whenever there's a problem or a better way of doing things is found. There's also a guide which is the fire assets and development, so that's all the draft fire assets which are not part of a sort of a official UK core release, but they're in the project. They can be used. They are part of the package release of the fire assets. They're there to enable people, just like prototypes, to be able to do early development. You can go into the H7 UK projects in Simplifier. So H7 UK has its own organisation in Simplifier, and HS Digital has one for its implementation guides, and the UK core is owned by H7 as such, and is in their Simplifier project. So it's in a separate organisation, and they have various other things there. You can, for instance, go to the Care Connect baseline, which is the latest and greatest of the Care Connect assets. You can also look at other stuff that's going on in relation to the core. So you can see things like the naming systems now, which are now based in Simplifier, that H7 manage, and things like that. And that's all for me.
Yeah, thanks, Kevin. I'll just jump back in. If anybody does have any questions, please just type them in the chat. I'm sure they can be called out. Yeah, Kevin's covered a lot of the kind of technical detail and progress to date, but another big part of this, and something I'd like to emphasise, is the whole approach is based around collaboration. It is a UK-wide approach. Like I say, we've worked very closely with Wales. However, there's been lots of challenges, I'm sure people appreciate, with COVID through that working. So we've probably not got where we wanted in terms of building a broader based development team, but that's still very much the intent. I really just briefly, obviously there's a limit to what we can cover in half an hour, so I'd encourage everyone to look out for the webinar, which is really meant to be probably a good 2-hour overview of the approach and the wider engagement. But just to say, to support that engagement, there's actually an ISN that in effect we as NHS Digital, so it's raised as part of NHS E&I, but we as NHS Digital have committed to the governance that surrounds the UK core. So it does not belong to us. We do put most of the effort into the development, but we do work very collaboratively to do so. So the ISN, and I don't know if we can share it later, but it's DAPB 4020, is around the governance approach to the UK core. There's a UK Fire Board that I think was touched on, and in effect the decision-making body around what should be done in the fire space for the UK. So that's co-chaired by HL7 UK and a separate team in NHS E&I. To support that, there's a UK Fire Delivery SLT, the keyword being delivery, so that body exists to deliver on what the Fire Board ask. I actually co-chair that in my NHS Digital role, along with Mark Frayne from Wales, so we alternate the chair of that. And I think we're very aware, and this is probably an early step, that we we haven't shared enough about the progress and the collaboration. A lot of effort has gone into creating the processes and development and building that alignment between everybody. I will take the opportunity to thank the Interoperable Meds team, who were a very early adopter. I think they recognise the benefit of having things in the core and a more centralised approach. And actually, we're now getting that benefit ourselves in that we can use those medications fire assets in other programmes and pieces of work. So we refer to the UK core assets as building blocks. And the more of them we build, the more they can be used across the board for a whole variety of activity that's going on out there. So yeah, just wanted to really cover that it's absolutely a collaboration. Anybody please get involved. There's various links available in the presentation. It is dependent on contributions to steer the direction of it. That's not something we seek to do or want to do, but obviously we take those steers and look to help drive the work forward. So as I say, we're planning in, we have had to move it back, but we're planning in the webinar will be the first thing, which will be a more detailed overview of the core. So for anyone who's not familiar or wants more information, that'll lead on to the Learnathon, which obviously follows a similar process here, where we'll start to build the approach for the hackathon, and then it will be our very first hack. So we're very keen to get people involved and get feedback, because it is that produces a better UK core, particularly fire, obviously UK core for everybody, and that's what we're really keen to do. So I think that's it from us, Daniel.
And thanks, Dave. So I think just in terms of the links, we will be sending out links to all the presentations so you can access them in your own time and also access the links. I've had one question from John Williams, and it's probably just worth giving an answer to everyone. So yes, we will be sharing the recordings for these sessions. So if you've missed anything, you can just access it in your own time. So I think I couldn't see any other questions. Well, there's one question from David Hancock just came. Will the UK Core Hackathon be based on UK Code 2.0.0?
I'll take the lead from a previous answer. Join the Learnathon and we can all discuss and agree if that's the best thing to do. But certainly open to that, obviously, and we should be well progressed by that point. So yes, thanks, David. But I'm not going to decide. I think we'll decide collectively on the Learnathon.
Thank you. And Dave just said, totally agree. Any other questions? If there are no more questions, then we'll move on. But thank you to Dave and Kevin. It was a really useful session. So I'll just move on to the next item, which is the PRSB diabetes standards. So Sarah Jackson and James are here to talk about that. So in terms of this session, they will just give you an update on the standard itself, the existing challenges, but also the future development work. So over to you. We will give you co-host access so you can share your screen. So who's sharing, please? Is it you, Sarah?
Yes, I will. Thanks.
So Jasmine or Georgina, if you can please give Sarah access, co-host access.
Can you see my screen?
Yes.
You can. Great. That's a good start. Thank you. So I'm Sarah Jackson. I'm from the Professional Record Standards Body, and I was just going to give you a quick overview of the diabetes information standards that we've been developing, where we're up to, and some of the things we wanted to explore a little bit further, particularly around sharing information about insulin, so insulin administration information. So apologies for those of you who know PRSB, but I do have a little bit of an intro to PRSB at the beginning. So I'll skip through that fairly quickly. Okay. Sorry, just trying to move the screen on. It's not working. There we go. Right, so we're the PRSB, the Professional Record Standards Body, and we define information standards. So what I mean by that is the information, the structure and the content of the information that needs to be available in a particular scenario. And what we do is we work with our membership, and our membership covers professional associations, system suppliers, and patient and public groups. So professionals across health and social care. We work with them to define what those information requirements are. This is a slide just showing some of our members. We have about 80 members now, and they're kind of national organisations essentially. Okay, I'll just talk a little bit about the diabetes standards now. So we were asked by NHS England to develop an information record standard for about a person with diabetes. And the sort of drivers behind this piece of work were to improve information sharing about someone's diabetes across the system, because there are examples of, for example, things like test results that maybe are done in primary care that aren't being shared with secondary care when the person's under a consultant-led care. Things like eye screening data is being shared with the GP, but then doesn't necessarily get, it isn't necessarily made available to the hospital consultant. Sharing information about foot checks, so if it's done by a podiatrist in the community, that information doesn't, about the foot check and the findings from that foot check, doesn't necessarily get shared. So it was all about how do we, well, defining the information that needs to be made available to the health and care team that sit across different care settings. And the second driver was around sharing people's self-management information. So at home, people might be collecting information about their weight, blood pressure, but also information from devices. So for example, continuous glucose monitors or connected insulin pens used for insulin delivery, or insulin pumps used for insulin delivery. All of that's a sort of lots of information that they're collecting and using to help them manage their diabetes. And currently, clinicians can access that information. However, it might be through multiple front ends, because they might need to use a particular front end to access the glucose information, and a different proprietary interface to access the insulin administration information. So what they asked us to do is to look at what's all the information that a clinician might want to see, and how can we develop a standard to enable that to be shared so that it can be viewed via the front end of choice for the professional. So what we did was we went through a consultation process to identify what information needed to be made available, and so that resulted in the standard for the diabetes record. And then we looked at the self-management information as well, so things like glucose and ketone information, glucose metrics as well, so summary metrics, blood pressure, foot check information. And what we ended up with was a diabetes record standard and a subset of that standard that would be used for self-management information. And this just shows some of the sort of information that would be in the record. So things like the investigation results, so that would be HbA1c results, cholesterol results, kidney function tests, etc. Structured education as well, that's really important in diabetes management. So clinicians were keen to know whether somebody had attended structured education, eye screening data, that all that kind of information would be in the record. And then vaccinations and observations. So observations might be the blood pressure readings or weight, for example. But as I say, what we ended up with was a subset for the self-management data of the overall record. So what we're doing now, so from that we've developed two information models, an information model for the self-management data and an information model for the record, the diabetes record, and the associated implementation guidance. And now what we're doing is working with the NHS Digital's IOPS team to map the PRSB information model to FHIR UK Core. We're also working with the NHS Digital terminologists on new SNOMED CT codes that are required, particularly around glucose and insulin data. And then there are some other codes needed around diabetes treatment regimes and driving status, for example, because that's something that's really important, needs to be recorded in the record. And that work's ongoing. But the next phase of work, we're looking to sort of test and pilot the standards, and NHS England is keen to take that forward. Okay, so as part of the consultation work we've done, we identified a number of sort of key scenarios where people have said information needs to be better shared. And this is a summary of some of those scenarios we've identified. So, and I think I've talked about some of these already, but eye screening results. So at the moment, the eye screening results will go back to the GP, but they're not necessarily getting shared with the hospital consultant. So and they're keen to, that they need access to that information. Test results again. So people told us that they might be invited to have some blood tests done by the GP practice, but then the results of that test aren't necessarily being shared with the hospital. So then they might be required again to go for further blood tests by the hospital. Sharing observation data, sharing the foot check results. So any kind of foot checks done in the community setting aren't necessarily being shared between the whole team, so with GP and the consultant. Diabetes status on admission to hospital, this came up, and I think this is also reported in the diabetes GIRFT report, the Getting It Right First Time report, that when someone's admitted to hospital, the hospital doesn't necessarily know that they have diabetes, and therefore can't or don't put the required sort of monitoring processes in place. So that was identified as an issue. And the two involve self-management data, so getting information from patients' devices into clinical systems. So in this case, from insulin delivery devices like insulin pumps or connected pens. How do we get all that data into clinical systems? And the other one was around sharing simple insulin dosing information on either admission into hospital or discharge from hospital. And by simple insulin dosing information, we mean what type of insulin is somebody on, what kind of regime are they on, what usual dosing do they use, so how much do they take at breakfast, lunch, evening meal, how much in terms of a bolus dose of insulin, what's their background insulin, is a device used, if so what device, who is responsible, who administers the insulin, so if they're in a care home, does somebody do it for them, or do they need to be referred for a district nurse to perhaps help them with their insulin dosing, and who monitors their glucose measurements. And then the other scenarios were around sharing care plans across the whole team. So a diabetes care plan, how does that get shared between a GP and the hospital consultant, and vice versa, how is it shared and updated? And then the other scenario was around structured education. So information isn't coming back from structured education providers and being coded into GP systems around attendance of structured education. So that's the other area. And the two scenarios in bold are the scenarios that we'd like to discuss here and take forward. So if I move to, so we've broken them down into three scenarios. We are keen to discuss these further and look at them at the hackathon. For each scenario that I'm going to talk through today, it would be helpful if you could consider, is work already happening in this space? Are there existing interfaces? Are there examples of where this is being done? And we'd be really keen to capture that information. So if I just describe scenario one, So this is sharing insulin administration data from a pump or connected pen with either hospital systems, GP systems, or care home systems. And this is, so there are different sort of sub use cases within this. One is around simple insulin dosing information. So this would be sort of manual injection up to about 10 times a day of using a connected pen. The second use case is sharing standard pump data. So that could be a basal infusion and standard extended or multi-wave bolus doses. And the third scenario sort of builds on that and is around sharing hybrid closed loop data. So a hybrid closed loop is when the insulin pump of the doses applied by the insulin pump is controlled by an algorithm that uses data from the glucose monitor. So this scenario would include sharing glucose data, the information about the algorithm, and the insulin data from the pump. So those are the three scenarios around sharing, or three use cases around sharing insulin administration data from devices. So as I said, what we're keen to understand is are there examples of this happening? How is it done? Are there existing interfaces, etc.? So if I just explain the second scenario, this is around sharing simple insulin dosing information, so information about a person's insulin regime at admission and discharge. So this is the scenario as I was talking about before. So this would be either sharing this information from when someone's discharged from hospital with a GP, care home, or district nursing team, and it would set out the information that I've described. So what's somebody's usual insulin dose at breakfast, lunch, evening meal, and then background insulin, who should administer it, who monitors the glucose, what type of insulin, you know, what's the insulin they're taking. So it's that information. And then sharing information if someone, for example, if someone's admitted into hospital from a care home in an urgent situation, sharing that information with the hospital diabetes team. So that's the second scenario. And the third scenario is the information about a medical device. So we want to hold in the record the information about the medical devices that a person is using. So this could be information about a continuous glucose monitor, information about the insulin pump, and it's information like when were they given it, what's the replacement date, is there a warranty associated with it, that kind of information. What's the make, the model, the software, the version number, all that kind of information about the actual device the person has. But then there's the other scenario, which is when information about an insulin administration is entered into the system, that needs to be associated with the device that it came from. So we need to know what device was used to deliver the insulin, and how is that, how should that be recorded and that information be shared? So again, so the questions I have are people sharing this information now? If so, how? Are they using FHIR to do so, the existing FHIR resources, and how's that being done? Okay, thank you. So I'm just going to move on to the question slide. So if anyone's got any questions for me, I'm happy to take them now, but then I wanted to ask, do people have any thoughts on any of those scenarios, any examples, etc.?
So Sarah, just to confirm, we managed to capture those questions in the Mentimeter, so people will be able to respond through that. So I can share the link in the chat again. I can also share my screen. So the link for the Mentimeter is in the chat. I will share my screen. So Sarah, if you stop sharing, I can share my screen so you can. So I hope you can see my screen now. So we've already got some responses. So in in this question, we managed to put scenario 1, but if you and you should also be able to see what scenario 1 is about. So, and then you can answer the questions. So I've shared a link in the chat. Please use a link to respond to this question. And Sarah, one thing that we probably didn't put in this Mentimeter is your information. So if you do want people to get in touch with you, could you please leave your email in the chat? Thank you.
Yeah, will do. Thank you.
So if colleagues can please take a moment to respond to these questions. We've got 3 or 4 questions. You should be able to, if you haven't responded to the previous questions, don't worry about them. You can do them in your own time. I think this is the 5th question on our slides. And I'll just move on to scenario 2 now. So, scenario 2, again, the scenario 2 is about information required about a person's insulin regime at admission and discharge. Again, the 3 questions are the examples of this being done, are there existing interfaces, and is work currently happening in this space? Again, it'd be great if colleagues can respond. And then the 3rd question is, I'll just move on. The 3rd question is scenario 3, which is information about a medical device that needs to be shared around the system. And again, the 3 questions are there examples of use of FHIR resources for sharing information about medical devices? Is the work currently happening in this space? And then I'll move on to the last question in this. So the last question is there any interest in exploring these topics further? If so, which ones? So again, if you can please answer this question, be much appreciated. I'll stop sharing my screen, but please do use the link to answer these questions. And Sarah's already put her email in the chat. Thank you for that. So whilst people are taking time to respond to the questions, do you have any questions for Sarah and James? Last opportunity. Any questions?
I think I'll steal my own thunder, but for my presentation later. But I think it's worth noting, Sarah, James, you're planning to come along to the hackathon with us to try and crack some of this and see how it maps into FHIR at that. So certainly the work streams that have been pulled up on the screen there will form part of the themes for a PRSB diabetes standard work stream at the hack, which you'll hear more about later.
Yeah. I was just going to the PRSB decision.
You're breaking up, David.
Okay, can you hear me all right? It's very
Still breaking up.
breaking up. Okay.
Can't hear you at all now. No, I think it's. We could hear you with the earphones on, but you were just breaking up. So maybe it was to do with your bandwidth as opposed to earphones. Okay, so thank you, David. David's left a question in the chat. So the diabetes standard is very large. What are the priority areas in it to start on? Ian just responded feet.
So I can just come in and just say one of the things we're doing at the moment is working through kind of a set of must-haves. So that will define it will define a minimum kind of product. But yeah, feet is definitely in there as well, one of the key areas. And it could be that so we're doing that with the clinicians now, working through what the key areas are. Just use one of these codes. Yeah. Well, so that maybe that's something we could look at actually. How do we narrow down what we say about the feet, recording the feet examination findings? So I think, yeah, that I think that's fair to say, and I think that is something we should look at, definitely.
I think absolutely in the spirit of the hackathons, you know, we'll go in there with an open mind as well and take these things on board. So the hacks are really about starting and finding the challenges. So we won't go in with all the answers, that's for sure, but hopefully we'll get some through the 2 days.
Indeed. So I think if there are no more questions, we probably have time for a quick break before our next presenters join the session. So we can give ourselves nine minutes.
Thanks, Sarah and James. Thanks.
Yeah.
Thank you.
Thank you both.
Thanks very much.
Okay, see you guys in 9 minutes. Hi, just to say for people who have just joined us, so we've given ourselves a short break. We will reconvene at 2 o'clock. Thank you.
This meeting is being recorded.
So Shazad, are you back? Yep. So welcome back, everyone. So next up we have Alistair Gray and Julian White from Lancashire ICS and Leo Martin Scott from Somerset and also Shazad Ali. So they're here to talk about their work on medicine's interoperability benefits. So without further ado, I'll just pass on to them. Thank you.
Thanks, Daniel. Just bear with me a second. I'm just going to try and share my slides. Just bear with me. Let me know if you can see it.
Not come up yet.
Not yet.
Just bear with me.
That's it.
See that? You can see Shazad.
Okay, thanks. Just bear with me a second. Okay, yeah, just good morning, good afternoon, everyone. So I've spoken before, my name is Shazad Ali, one of the clinical leads in the Digital and Interoperable Medicines program. There's a few of us here to speak to you today about the work that we've done in terms of the consolidated medicines record. Just before we go into that, I think it'd be useful just to have a quick introduction. So I'm just going to mention that David unfortunately couldn't join us today, but he's contributed significantly to this work. Hence, we thought it was only appropriate to have his name still here. And with that, I'll just hand over to Alistair.
Yeah, Alistair Gray. I'm the Chief Pharmacy Information Officer at East Lancashire Hospitals, but also the clinical lead for the Unified Medicines Record with Referrals Project for Lancashire and South Cumbria ICS. And I'll hand over to Julian Wyatt.
Hello, I'm Julian Wyatt. I'm a pharmacist by background, but now working in the digital area. And I'm the project lead for the Unified Medicines Record and Referrals Programme. And we've been collaborating very closely with Somerset FT. So I'll hand over to Leo Martin Scott.
Thanks, Julian. And I'm Leo. I'm the Digital Medicines Lead Pharmacist at Somerset NHS Foundation Trust. We've implemented EPMA at our trust and are now looking to use interoperability to create a unified medicines record utilising medicines data from across Somerset.
Thanks, Leo. Okay, so I'm just going to move this along. Okay, so we've just kind of discussed who we are. And so what we're going to do as part of the agenda today is to actually talk through what actually is a consolidated medicines record and the journey so far. So there's been my colleagues here from Somerset and for Lancashire and Cumbria. So we're going to be talking about the actual work that's been undertaken so far. And I think initial data collection that was carried out by Somerset that they kindly shared, and where they captured a lot of the medicines related information for patients when they've been admitted into hospitals. And then how we kind of engage and made sure that that was able to be shared with colleagues in South and Cumbria and Lancashire. And in that way, they're able to create a next iteration of a questionnaire, which will allow, hopefully, for medicines information to be collected baseline prior to an implementation of shared medicines information, and then potentially what the future may hold thereafter as well. But hopefully, it can be utilized by people going across the country as well. They're doing something similar in the future. So this is the vision statement that we have centrally. So just to mention that what we do within NHS Digital, as mentioned earlier, was to kind of do a bit of matchmaking. So hence, like Somerset and South Cumbria and Lancashire getting together. And then we've also helping to create those standards as well that we mentioned earlier in terms of DM&D, fire standards, SNOMED, CT, and UCAM as well. And we were able to make sure that that information for clinicians and for NHS staff is there, so they can have the right information at the right time to make the right informed decision as well. And as you can see, there's a number of different areas where that can happen. And so, as we spoke about earlier, it's incredibly complex. What we can try and do is help to facilitate this conversation so they move in the right direction. And just quickly, I think Fintan mentioned this earlier in terms of different areas that we work on centrally in terms of the electronic prescription service. So hopefully we can have it not just in primary care, but other settings as well, potentially in the future with hospitals and maybe dentists in the future as well. At the heart of it, we've got the interoperable medicines work that we're carrying out, where we created those fire standards and DM&D developments, and also SNOMED that we spoke about earlier. But then also the data, medicines data as well. And that all feeds in to allowing that information to be provided to NHS staff in a quick manner and a consolidated manner as well. I think that's what's key to making sure we can provide safe care. So in terms of the work that we've done so far, we created those standards, had an ISN, have dose and tags as well. And so that, as a result of that, then we were able to provide that information for system suppliers and organizations to share that information, whether they use EPMAs or electronic patient records, and that way those benefits can be maximized. And as we spoke about earlier, there's so many different areas that this can occur in terms of acute trust, mental health, clinics, GP outpatients, etc. And it's not just medicines related information, it's also allergies information. And Leo will talk about some of the work that they've done, great work that they've done in Somerset. And also Julian and Alice will talk about the great work that they're doing in Lancashire and South Cumbria in terms of how they've actually tailored some of that standards in the work what they've carried out in terms of actual consolidated medicines record to localize it for their particular areas, whether it's in the emergency department, where they have critical medicine alerts, and also potentially anticholinergic burden scores as well. And also within Lancashire and South Cumbria, they've also done the referrals as well with the refer to pharmacy application as well. And so that's also beneficial for the ICSs as well, in order to have that information shared across the various care settings which lie therein. And with that, I will hand it over to Leo, who can give us a take on the Somerset work as well. Leo.
Lovely, thank you, Shazad. So if you just move on to the next slide, please. So we have our CIDR record, Somerset Integrated Digital Electronic Records, and this is an accumulation and amalgamation of the medicines related and allergies information that is recorded in all different settings across Somerset that have made that data available as part of a shared data agreement. So it's not just limited to previous admissions at our acute trust, but we've also got discharge information from other acute trusts, so Yeovil District Hospital, from our community mental health sites, as well as from our GP records. And it's starting to put together that amalgamated view of a patient's medication record. So next slide. So some of the general challenges that we're having with with making this data available and directly consumable within our e-prescribing system is getting around some of the differences between primary care prescribing and secondary care prescribing. So we're looking at product-based prescribing in primary care versus dose-based prescribing in secondary care. We've got some interoperability issues in terms of the build of levels of structure. So we don't always have machine readable data coming from one system to another. It's often free text rather than using the structured dose syntax. And some of this information is also relating to medication status. So what might be considered an active prescription in a primary care system might actually not truly be active for the patient. And I believe that differentiating between a repeat and acute prescriptions is currently not consumable in the FHIR message. So it creates some difficulties there. Not all systems are using DMD and SNOMED. Some use their own in-house systems. And then those that do use DMD or SNOMED structured drugs, you have to then have an alignment between SNOMED code. So if one system is out of date or ahead of the other, you then lose some of those benefits of interoperability. You've got difficulties with user interpretation of information and how best to present the information. So where you've got multiple sources of information, it's making sure that the most up-to-date information is presented in the right order. And a lot of the information that we have is incomplete or not compatible with dose syntax. So again, it requires a level of transcription or interpretability by the user. So we can move on to the next slide, please, Shazad. So this is a GIF showing a prototype of the central record that is feeding directly into our e-prescribing system. So you can see there on the left-hand side, we've got multiple different healthcare organizations. We've got the prescriptions related to those and their current status. And where the prescription information is structured by dose syntax, it is automatically populating those fields into our e-prescribing system to make the process of recording that drug history and prescribing those medications as easy as possible. So next slide, please.
So I think that's me. We are working in a slightly different situation in Lancashire and South Cumbria to Somerset. We have 4 acute trusts and a mental health trust. And there have been a number of challenges in achieving the aspirational goals from the slide that Shazad showed earlier. One of the biggest issues we've had so far is actual interconnectivity between the trusts to share data into one central platform. We're looking at actually having a persisted record in a clinical data repository. And so therefore those connections are really important. The other problems are the fact that across the 5 trusts in total, 2 have an implemented EPMA system, 2 are in the process of implementing an EPMA system, and the other has a standalone system. So the difference in digital maturity from currently 1 trust on paper records to a fully implemented EPMA has also caused issues and difficulties in pulling data together. And this will mean that the record will have to build up in a number of iterations. What we're aiming to do, though, is to integrate the records into our already established shared care record viewer, but enabling it to come in as structured data so that it can be displayed in ways appropriate to the clinician that's viewing it. The other thing is that this is a new way of working across multiple trusts as the ICS has formed and become the ICB. So getting 5 tech teams to work together and various other functions within those trusts that need to now collaborate. One of the big areas as well was around IG, and again, 5 IG teams. So the decision has been made that we'll have 1 lead IG team, which will work through the necessary DPIA, etc. And then we'll share that with the other trusts for them to sign off. The other problem we have is that some of the more critical prescribing occurs in smaller specialist systems. And we've already been having discussions particularly with the community drug and alcohol teams. However, it seems that the data in their systems is not coded at the moment, and that causes another big problem to be able to pull that into a structured record. So there's a lot of work to do to get from where we are today to that final aspirational description that Shazad gave. But we are starting to make progress, and we hope to have a pilot up and running in the next 4 to 8 weeks by the end of the year, hopefully, where we'll get our first set of structured data from an EPMA across the central record and displayed in the shared care record viewer. And then it'll be iterative steps to bring in other prescribing sources. One of the key things, though, now working as an ICB, is to also get 5 trust finance teams on board. And for that, we really need to look at what benefits this brings. So I'm going to hand over to Alistair and the next slide to discuss that further.
Okay, so we've involved some academic support from Professor Rachel Elliott and some of her colleagues from the University of Manchester who've been commissioned by NHS Digital. Plus, we've got our own sort of team locally looking at what are the benefits realization. So the first thing we're looking at is reduction in harms, and I'll shortly be showing you or demoing a survey we've got, which starts with a likely harm reduction. We predict that there will be more medicines reconciliations done in a given time period, because it should take less time to actually complete the medicines reconciliation process. So for a given number of staff, more should get done, and earlier in the patient's stay, which is critical to sort of meet the NICE standard of within 24 hours. We predict that because everything's interoperable, there should be fewer transcription errors identified and therefore needed in fixing, and actually more clinical reviews taking place because there's a richness of data. I think Shazad mentioned we're hoping to have the anticholinergic burden scores displayed in the record, so people can start thinking straight away about reviewing and reducing that score, and also highlighting people who are on critical medicines when they're admitted to hospital, so they can be targeted early in their ED stay, for example. We want more people to see stuff when they need it. So our view is at the point of need, everyone sees, any clinician sees exactly what they should see in order to make the right decisions. And finally, we predict an improvement in medicines adherence, leading to better health outcomes and fewer readmissions to hospital or ED attendances. And I think the next slide is back to Julian.
Thank you, Alistair. So if we could have the next slide, please. Thank you. So, as I say, it's really important that we're able to measure where we are now to be able to see what benefits the interoperable record brings. So, between ourselves and Somerset, we've been working on a baseline survey or a point prevalence audit that could be undertaken. The plan being that we'll take snapshots now before anything's implemented. And then as each iteration of the interoperable process is developed and becomes live, we'll take another snapshot to see what benefits are actually occurring and to see whether we can reduce that 70% of medication errors that is potentially out there. In addition to this, we feel that we could also look at the number of reconciliations that are being done and whether that increases as a result of the interoperability, whether readmissions falls, and whether the number of medicines-related ED attendances drops as well. Additionally, there's data already in the systems, we believe, which we can analyse, so tracking and looking at incident reports related to medication errors, and tracking utility and users, people who actually use the interoperable record, and the number of hits that we get will show how beneficial this is. In Lancashire and South Cumbria, as Alistair mentioned earlier, we're tying this in with referrals and the referred pharmacy platform to share information to community pharmacies. So we hope to see an increase in DMS and NMS activity and the number of pharmacy referrals that are undertaken. And I'll hand back now to Leo from Somerset.
Thank you, Julian. So I'm just going to take a few moments just to run through what we did in Somerset and then pass back on to Julian and Alistair. So we did an observational study where one of either myself or my team would go out and observe pharmacists recording drug histories, the different sources of information that they were using, and the time they spent recording those the drug information from different sources, and then also the time they would spend transcribing that information from a source to a paper record or into our e-prescribing system, whichever area they were currently working in. We would then total the time for completing that drug history and the time and the number of items, recorded in that drug history to get an average time per item. And then we also allowed for the recording of discrepancies between the drug history recorded by the clinician, if it was present, and the drug history recorded by the pharmacist. So we would have some baseline data in terms of mapping the number of interventions pharmacy would have to make, as well as the average time it would take for a pharmacist to complete a drug history of an average number of items. So this baseline survey, so to speak, was then adopted and adapted with the support from Julian and Alistair. I think Alistair's going to give us a quick demo of that.
Okay, I'm going to attempt to share my screen by clicking on a particular thing. Share that. Right, hopefully you can see it's a Microsoft form. Give me the thumbs up or say yes if you can see it. Yeah, okay. So a bit of blurb. The first thing is we ask whether any harm could have occurred if you hadn't done whatever you were going to do. And this is the biggest input we got from Rachel's team because we didn't have anything about tracking harm. So the survey starts by saying, after you've done the reconciliation, and I should say it takes about 2 minutes to complete this form. It's branched, so depending on what questions you ask, you get sent down certain avenues to provide a bit more information. So average pharmacist or technician probably does maybe between 5 and 10 reconciliations in a day. So it's not adding a huge amount of time onto their working day, but it's providing for the week of intervention recording we'll be doing huge granular depth of information. So let's say no harm came. This will be tailored to the site. We've got 4 sites in East Lancashire, and then it asks you which specialty and what was the role of the person taking part. Were any problems found and interventions made? Depending whether, if you say yes, one particular question comes up. If you say no, you get a different one. Did you do the drug history or did someone else do it? Because they might be adding extra bits of information in there. I'm asking how long you spent on it. So we're not going to be doing the observational study down to the second as Leo did. We're just getting in 5 minutes sort of aliquot. So if it's longer, then you can record a bit longer. But we want to know how long it took to obtain the history itself, not how long it took from start to finish, because you might have gaps while you're waiting for information to come back. So it might say it's 10 to 15 minutes at the moment, but actually it took 5 hours from start to finish to actually complete the stuff because we were waiting for calls to come back. How many medicines the patient was taking gives us an idea of why maybe it took so long to do. And the age of the patient just helps to sort of reconcile. It's more likely people of a higher age have more medicines. There's an optional question there, and then it asks you what sources were used. I can tick a few of those, whatever's relevant. Did he make a phone call? If you say no, you get a different question to see if you say yes, because it asks you how long it took and why did you make it, because we're looking to find out whether we make less phone calls when we get the Unified Medicines record in place. Was anything in faxed? Well, it won't be faxed now, it was scanned and sent. If you say yes, well, how long did that take, and why was that needed? And was there any impact on treatment due to a lack of information available? So if you say yes, you get a different question to say if you say no. And finally, you can add a bit of free text and sort of rate your medicines reconciliation experience for that particular patient and click submit. Now, I've avoided some of the branches just to illustrate the process, but pretty much anything you can think of, we've asked. So we'll get a vast amount of data at the end of that. Now, if I can stop sharing without cutting the call out, that would be good. I think a final slide was to ask if anyone had any questions.
So I think there's a question from Mike. So I think it says, any questions on how long it takes to transcribe the medication?
We've kind of bagged that together with obtaining the information and getting it onto a prescription list or a prescription chart. So it's covered by that, because again, our prediction would be we'd see a reduction because it'll take less time to do.
Yeah, I was just saying, so it's clear to the person filling in the form that it's not just how long I get it on a piece of paper in front of me, it's also the time I take to type that piece of paper into the EPMA, probably.
Yeah.
Yep. Okay.
We will check that, because for those on paper still, then there's still transcription. We'll check that that's covered. If it's not, we can add an extra question in.
Thanks, Mike. I think there were some other questions that have been answered already. Any other questions? I think that's probably it. Thank you so much, everyone. Really helpful information. Thank you all, Leo, Alistair, Julian, Shazad. I think we can probably move on to our next item. Alistair referred to someone called Rachel Elliott, who provided input into this medicine interoperability service. Rachel was meant to attend this meeting, but unfortunately she had a clash with NICE meeting, so she can't make it, but she has recorded a video for us. Just a bit of background about Rachel. Rachel is a professor in health economics in the University of Manchester. She was a project lead for the research on interoperability work. So I'll share my screen and so that you can see the pre-recorded video. Just bear with me 1 second while I try to get it out.
And obviously, any questions from this section, please put them in chat or take them away to Rachel, and she's committed to answer those directly. So if you do put them in the chat, we can follow up for you.
Thanks, Chris. I hope you can see my screen. I'll just press and just to test if you can all hear and see the video perfectly.
No sound at the moment, Dan.
Hello, everyone. My name's Rachel Elliott. I'm presenting some work that we've done for NHS England, estimating the impact of medicines interoperability solutions in the NHS in England. This was a small team based in Manchester. Myself, Liz Camacho, Sean Gavin, Richard Kears and Anthony Tutor. The work was funded by NHS England. So just a brief bit of background. I'm sure everybody is aware of the World Health Organization Challenge on Medication Safety, which challenged healthcare systems to reduce harm from medication errors by 50% back in 2017. And one of the key areas that they focused on was the transfer between care settings and set that as a priority area. And the World Health Organization particularly highlighted frequent transition points where there might be medication errors in healthcare settings, as admission to hospital, transfer from one area within a hospital to another, particularly where there are separate paper or electronic records, discharge from hospital, transfer from one hospital to another or to a residential care setting, for example, a nursing home or rehabilitation facility. So we know that the information that the NHS holds about medications and allergies is often fragmented, stored in different formats, using different vocabulary, and this is often cited as a reason for being difficult to share this type of information. And in order to get around this, NHS Digital estimates per year in England that there are about 167 million hospital transcriptions, consuming 1.2 million hours of hospital staff time and 9,000 weeks of GP clinical or administrative time. In addition to this time being wasted, this lack of interoperability between care settings is known to lead to medication errors where drugs are missed off added to prescriptions, the wrong dose is transcribed, the wrong frequency, or allergy information is missed. These errors are often referred to as transition medication errors, which is what we will refer to them in this presentation, or unintended discrepancies. And they are known to cause or thought to cause harm to patients and cost to the NHS for managing that harm. So the aim of medicines interoperability is that by sharing medicines information, this will allow the reduction in medication errors through stopping or reducing rekeying of information. So not only increasing availability of staff time, but this will increase patient safety and also lead to quicker discharge, better healthcare planning, and supporting other care processes such as electronic prescription service. So the aim of our study was to focus on one aspect of one of the anticipated benefits or impacts of interoperability, and that was to estimate the expected impact on medication safety following the implementation of information standard ISN DAP B4013, and look at the impact of that on patients and to the NHS in England. And this was done by asking and answering the following questions. What is the incidence of medication errors at key transitions? What is the patient harm and NHS cost of these errors? And how will improved information transfer impact on medication errors, associated patient harm and NHS cost? And we used available published evidence and stakeholder and expert input. So the population that we investigated were people at risk of experiencing a transition medication error at 4 key interfaces. So primary care to secondary care to primary care, within and between hospital transitions. And the intervention that we were interested in testing was digitally enabled interoperable medicines information transfer. And this was compared with what is standard practice, which we refer to as manual or non-interoperably enabled medicines information transfer. And how do we measure the impact of this intervention? We looked at studies that had measured transition medication errors or discrepancies, hospitalizations, adverse drug events, length of hospital stay, readmissions, and deaths. And the study took the following structure. We did 3 related literature reviews. One review looked at error incidence. The second looked at the harm and costs associated with those errors. And the third review looked at the effect of interoperability solutions on any of those outcomes. And we used these 3 reviews and their findings to allow us to estimate the effect of interoperability solutions on transition error prevalence, patient harm, and NHS cost for England. And all the way through this project, we liaised with stakeholders and experts in this area from NHS England, NHS IT leads, hospital and IT pharmacy teams, prescribers, suppliers, patient safety experts, and patient experts. So the transitions that we have included in this study are the 4 that are described in this simple diagram. And you can see that they are the transition of admission to hospital from the community and the discharge of patients from hospital to the community. And we've also looked at intra-hospital ward or unit transfer, where there is transfer from one electronic prescribing system to another, such as going from an emergency department to the ward or from intensive care to a ward. And we've also included inter-hospital transfers where patients are moved from one hospital to another. Some of the assumptions and exclusions that we made, given that it is expected that all hospitals will have electronic prescribing on standard inpatient wards from next year, then we have assumed that prior to ISN introduction that all acute hospitals will have EPMA for inpatient wards. So therefore we have not included any chart rewrites in our estimates. We've also assumed that in England, standard medicines reconciliation, generally done by pharmacists, is carried out during an inpatient stay. Due to lack of evidence for some of the transitions, we have excluded some transitions. So we haven't included data from ambulance trusts where patients change GP practice. We haven't included private hospitals. Our national estimates cover England only, although we have included studies from the United Kingdom to inform those estimates. The impact of EPS2, we haven't looked at the hospital prescribing dispensing interface. This was due to lack of data. Outpatient and emergency community pharmacy. Our estimates do include maternity and paediatrics. So our first review looked at the prevalence of medication errors. So the methods that we used were to source UK and, if necessary, non-UK studies reporting error rates across included information transitions. And then we extrapolated to national estimates using denominators for England identified from routine data. For example, looking at the number of finished admission episodes. I would say at this point that there is a report that's been submitted to NHS England, along with a summary and a plain English summary, which details the methods. And so this should be available quite soon if you would like to see more detail about how we put this information together and these estimates. And we also then looked at, once we knew the number of errors in terms of prevalence, we then looked at what proportion of these errors were able to, had potential to cause harm. And this was estimated from studies that had measured this particular parameter. When we looked at harm or the burden of these transition medication errors, fortunately, we were able to use UK studies. So we used studies that the Davis study, which looked at adverse drug events observed in patients who were in hospital. And this measured how common that harm was from an error. And then it also looked at the impact on their stay in hospital and whether they what proportion of patients with an adverse drug event died. Looking at the harm associated with patients being discharged from hospital with a transition medication error, then we used data that looked at how many patients were admitted to or readmitted to hospital with an error. And we were able to use English studies from this. And we were also able to use the error rates and multiply that by the proportion leading to harm from the Davis study. So the methods that we used to look at interoperability on transition medication errors, well, we looked at a very wide range of literature. We looked at many reviews, reviews of reviews, primary studies, the Cochrane review, lots of meta-analyses. And again, as I say, there's more detail available in the report. We didn't find a study from the UK that was relevant to the question in terms of what is the difference in error rate between a standard medication reconciliation process compared with an interoperably supported medication reconciliation service. We also didn't find any studies that examined intra or inter-hospital transitions. We used a study by Zoni that looked at the impact of interoperability on errors at admission to hospital, and they reported that the relative risk of an error was 0.53 once the interoperable intervention was layered over standard medicines reconciliation. And we used this estimate for admissions. We also assumed that patients moving to a different ward or to a different hospital could be classed as an admission event. So in the absence of specific evidence, we also used this estimate to estimate the effect of interoperability on these transitions. We didn't find an appropriate UK study to look at the impact of interoperability on discharge, but we did find a US study that gave relative risk of an error being 0.69 after the interoperable intervention was layered over standard medicines reconciliation. Error rates prior to interoperability, but with standard medicines reconciliation were multiplied by relative risk to estimate the prevalence of errors after interoperability. This schematic diagram just shows you the prevalence data that we generated from the literature for each of the 4 transitions. And you can see that the top row of data presents the prevalence of medication errors. And then the second row estimates the prevalence of medication errors in the presence of standard medicines reconciliation. And then we have then estimated the medication error rate with interoperability standards layered on top of standard medicines reconciliation. And you can see that this has a further impact on reducing transition medication errors at these 4 setting transitions. This table provides a brief summary and overview of the prevalence of transition medication errors, associated harm and NHS cost per year for England. And the parameters that we have reported on number of errors, and you can see that it's about 1.8 million overall for England in 1 year, and that 369,000 patients a year experience at least one transition medication error. And of these patients, 31,000 experience some form of harm, leading to 36,000 bed days. And these bed days are a combination of patients being admitted to hospital due to a transition error, and also patients staying in hospital for longer due to a transition medication error. This translates into about £17.4 million in extra bed days costs, and we estimated that there would be an additional 44 deaths per year in England due to transition medication errors. This is the data in the presence of standard medicines reconciliation, so in the absence of the interoperability standards being introduced. This table now provides a summary of the results of our estimates, where we looked at the impact of interoperability on these transition medication errors and the associated harm NHS costs per year for England. Again, we've reported them by transition and total. So you can see that if we assume that we use the number of medication errors from the previous table and the reduction in medication errors we've assumed in the earlier part of the presentation, this will mean that we will reduce the number of medication errors at transitions by 713,000 per year once we've introduced interoperability standards. And this will reduce the number of patients with at least one error by 148,000, the number of patients who experience harm from the error by 12,500, and it will reduce the number of excess bed days due to harm by 14,000, with an associated saving of £6.5 million, and also reduce the number of deaths by 20 in England per year. So just to finish, there were quite a few limitations associated with this piece of work, mostly due to the lack of data. And we've had to make assumptions, and this leads to uncertainty around our estimates. Because of the uncertainty, we've used conservative estimates where needed, so which suggests that our estimates may be an underestimate of the total number of errors, harm, and costs. We've had to exclude some transitions which will further reduce our estimates. We've got studies based in 1 or 2 hospitals in England and then extrapolated those data to the whole of the NHS in England, which of course is an assumption around generalisability. We've also only been able to look at the short-term burden of errors here in terms of impact on length of stay. We haven't looked at wider impacts of those errors on patient harm and costs. So this will mean that our estimates of harm and costs are an underestimation, most likely. We've also assumed that standards medicines reconciliation is in place. However, despite the limitations to the piece of work that we've done, it seems fairly clear that medication transition errors persist despite standard medicines reconciliation, which is in itself a very effective way of reducing transition medication errors. Improved interoperability from the planned information standards implementation will substantially reduce transition medication error prevalence and the associated harm and cost. It's always easy to say we need more data and we need more research. In this particular instance, we need better data around the proportion of patients really undergoing medicines reconciliation and how long after care transfer this occurs. We also need to understand the transition error prevalence at the omitted transitions, both before and after the information standard implementation. Thank you very much for listening to me. And if you have any questions, then please pass them to the organisers of today, and I'd be happy to take questions by email. Thank you very much.
That was it. Yeah, as Chris and Rachel said at the end of the presentation, that please share your question and we will collate and take them to Rachel for her response. And there's one thing I would like to share. I think these are the last 90-meter questions. So I will share my screen again. So I hope you can see my screen now.
Yep, that's good now.
So yeah, so the first question in this one is, at your side, have you measured error rates at any of the information transfer rates we have discussed in our presentation, either before or after? So it'd be great if you can respond to that. I'll leave it for a couple of seconds before I move on. Okay, so I'll move on to the next one. And again, you can answer in your own time. The next question is, do you have any examples, data of where an information transfer error has resulted in actual harm to a patient? Yes, no, unsure. And then I think it's the last question here. If you are happy to be contacted on this subject, please fill out this form. So again, I think it'll be your name, organization, and your email. And we'll put you in touch with Rachel. So I think that's it on the Mentimeter questions. I'll stop sharing. So at this point, I think that we've got two options. We are half an hour. Well, it depends how we look at it. So we can either take an early break, or we can go into our next presentation and finish a bit early. Chris, I think you're the probably only person presenting who will be impacted by this.
Yes, Joe's is recording, but she will be joining later on. So why don't we take till 3 o'clock as a break and then just run through the last two bits, because I know that Joe's other meeting, she can only join at the last little bit. So let's do it that way around.
Yeah, sounds good. So I think we'll give ourselves until 3 o'clock. Come back, everyone.
This meeting is being recorded.
I've shared my screen. I hope you can see the video. So this session is from Joe Golding, who is a terminology consultant, terminology specialist at NHS Digital. Unfortunately, Joe couldn't join us as well, but she pre-recorded this video. She's hoping to attend the last half of the meeting so she can answer any questions that you may have. So please feel free to put them in the chat. We've also got colleagues who might be able to respond in Joe's absence. But this session is really about an insight into the plan enhancements to DMND and SNOMED CT drug extensions, and to align these two terminologies, highlighting any benefits and acknowledging impacts for the users. So I'll press play.
Good afternoon, I'm Jo Golding, Consultant Terminologist and Business Strategy and Product Lead for Pharmacy Terminology at NHS Digital. Apologies for not being able to make it in person this afternoon, but I will try to dial in for any potential questions at the end of the day. However, if I don't make it, there are contact details to send questions to at the end of this presentation. The purpose of the session is to give you some insight into a number of enhancements that are being planned to be made to DMD and the SNOMED CT UK drug extension. To set the scene, first a little bit about DMD and the drug extension. I'm not going to explain each terminology in great detail, that's a whole other Learnathon. I'm expecting everyone here to have a basic understanding about each already. All I want to do with the next couple of slides is to give a little history and context to basically explain why we need the enhancements that I'm going to talk about. So first, the history. We started designing DMD at the turn of the century, and we designed a purposely simplistic model, 5 key boxes, each box to support several of the use cases that we had collated during our requirements gathering stage. These are all listed on the slides, I won't go through them. For every concept in DMD, no matter which box it's in, there is a description, the human readable bit, and a code, the computer readable bit. And one of the original key decisions was that we would use SNOMED CT identifiers as a unique identifier for our core concepts, including those seen in this slide, the VTM, VMP, AMP, VMPP, and AMPP. We went with SNOMED as at the same time we were building DMD, our clinical colleagues were also building a new clinical terminology, SNOMED CT, to replace the read codes. We wanted one identifier set to be used across medicines and clinical. The reason DMD grew up alongside SNOMED CT clinical rather than as part of it from the outset was, of course, political. Let's just suffice to say that's what happened. Around 2006, however, further to feedback that it would be really useful to present DMD in SNOMED format, and also with the burgeoning requirements for secondary care that we needed more information that DMD at the time wouldn't hold. Connecting for Health, as NHSD was then, designed and built the SNOMED CT UK drug extension. The drug extension is built on the core information from DMD. It therefore takes the 5-box model content direct from DMD, but it then also adds extra information. For example, as shown here, SNOMED is a 6-box model, as we also add in the trade family to support the extra use cases. Again, these are outlined on the slide. We also add a whole plethora of ref sets to support secondary care prescribing and various other bits to also support secondary care. And we don't take all the content from DMD. We don't include prices, for example, in the drug extension, whereas they are in core DMD. Over years of development, DMD and the drug extension have increasingly diverged to the point now where even based on the same core concepts, the same core identifiers, they can be seen as competing standards. What started with good intent, mainly to support secondary care, has created issues with interoperability, and we now have some serious alignment challenges. The first issue is differences in content. For years, we've been adding information to the drug extension to support secondary care, as I said. This addition of information means we have an increasing misalignment of information between DMD and the drug extension. The second issue is timing. Because NHS Digital have to build the drug extension on top of base DMD data, it means there's a time lag between releases. We release the drug extension every 4 weeks. We take the weekly DMD release, do our transform and extra authoring, and we then bundle up 4 of these and make a release. So we have release, 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 bundle it all up, then it takes about 1.5 to 2 weeks to finalise and drop the drug extension release. So it says here there's about a 1.5 week time lag, but from the first release of the 4 in the bundle, that's about a 5.5 to 6 weeks time lag in data going live. So in short, we have a misalignment of data and time lags in release. But why is this a problem? Well, it gets problematic if you have one system taking their data from DMD and another from the drug extension. Generally speaking, GP systems take the DMD XML releases because this is a requirement of EPS to do so. Secondary care trusts tend to use the drug extension because of the extra information that we include to support secondary care. If a GP system and trust system are trying to exchange information on, say, referral or discharge, there's a potential mismatch in codes and information, somewhat of a problem for interoperability. Therefore, to support interop, we must have the same data at the same time. It can still be available in different formats because system suppliers have different setups and they like the choice, but to support interop, we have to have same data, same time. In other words, we need contemporaneously synchronous releases. So what have we been doing about it? In 2021, Department and NHSE commissioned an independent review, a discovery piece of work to lay out exactly what the problem is. Was it really a problem, or was it theoretical and it was just me worrying too much about it? There's a wide consultation as part of the discovery piece with stakeholders, system suppliers, users, and a report with recommendations was issued in September 2021. The report concluded that each of the terminology formats had their place in the system, but due to divergence of content and the differences in release schedules, they were completely competing terminologies. To move forward, one core set of data with potentially multiple release formats was the only way to go. The report made a whole host of recommendations on how we could do this, and in October 2021, a cross-organisational steering group was formed, tasked with looking at the recommendations of the report and finding the best way to deliver contemporaneous synchronous releases. Subgroups, working groups were formed, and between November 21 and March 22, we've been researching, analysing and coming up with options on how best to proceed. The options and recommendations were formed and in July 2022 presented to the steering group, and they gave their approval to proceed with the 10 enhancements or changes to DMD and the drug extension in order to move towards delivering contemporaneous synchronous releases of DMD and the drug extension. And these are the 10 enhancements I'm going to talk you through today, give you an overview of what each one is and some examples to help hopefully try and explain them a little bit better. The first enhancement is to uplift the current DMD VTM content to link to contains only VTMs in the SNOMED International Edition. The top levels of DMD, the VTM and the VMP, are, where equivalents exist, linked to the SNOMED CT International Edition. This is done by DMD using the International Concept Identifier as its unique identifier. However, recent changes to the SNOMED CT International Edition model and the editorial policy mean that the International Edition definition of VTM and the DMD VTM definition no longer align. In DMD, the VTM groups together VMPs that contain only that VTM, what we refer to as contains only X semantics. SNOMED CT International, however, has just changed the definition of these existing concepts that DMD links to contain some. In other words, the VMPs below this VTM contain this VTM and possibly something else too. So they've moved to contains some semantics. And at the same time as doing that, they've introduced new contains only concepts. Therefore, some DMD VTM content is now linked to incorrect concepts in the International Edition. This will have implications on implementations using VTM and VMP inheritance and links to support things like allergy. This therefore means that we need to investigate all the VTMs linked to core international codes and change the correct contains only VTM where applicable, and where a new international contains only VTM doesn't exist, we'll assign a UK namespace ID. The next slide will give you a bit of an example of what this means in practice. This is purely a snapshot of what is currently in SNOMED CT for codeine and paracetamol. It's a snapshot. It's only a handful of concepts to demonstrate the point. It's not everything that's actually in SNOMED CT. It's just a handful of concepts to demonstrate the point. The VTM in orange is the DMD. This is cocodamol. And we are linked to the international concept highlighted here, 412556009. Historically, this concept was named paracetamol and codeine, brackets, product. And we're linked to this applying the synonym of cocodamol, as this is the British approved name, but internationally codeine and paracetamol would be used. Different names applied, but the same thing conceptually. And we've been linked to this International Edition code since 2002. However, as I just said, in the last few years, SNOMED International have done an overhaul on their medicines hierarchy and model within the SNOMED International Edition. The key changes are changes to the definition of VTM and VMP. They actually used to use the acronyms VTM and VMP, but with their redefinitions, they have actually changed the names of these concepts now to a medicinal product and clinical drug, respectively. So medicinal product is a new VTM, and you'll see it used here in the semantic tag between parentheses at the end of the name. Anyway, the core changes they made to the definition is the significant one. As I said in the previous slide, in DMD, VTMs and VMPs are what we call contains only. So a VTM of paracetamol to us means this VTM and all the VMPs under it contain paracetamol and only paracetamol. In the International Edition, they're now split between contains some and contains only. The contains some means this VTM and associated VMPs contain this thing, but may contain something else too. So going back to the concept in orange, paracetamol and codeine product, and our co-codamol VTM is linked to it. And to us, this means that these products contain paracetamol and codeine and only paracetamol and codeine. But you can now see the SNOMED has changed to product containing codeine and paracetamol medicinal product. And by this, they mean it can contain codeine and paracetamol, and it can contain other stuff too. And you can see that now, because you have the extra stuff in there too, you have Migraleave that also contains buclazine as a child of this concept, which under our definition of a VTM is incorrect. To make matters worse, SNOMED have introduced this concept of product containing only codeine and paracetamol medicinal product 7753600007, which is now a contains only and what we should actually be linked to. As you can see, the hierarchy in SNOMED is now a bit of a mess. At the top, we have paracetamol medicinal product and codeine medicinal product that are linked to in DMD as VTMs because SNOMED has changed the definition. They are now parents of paracetamol and codeine medicinal product. In DMD, they're all siblings. So we're starting to get all sorts of inheritance issues that we hadn't before, that we hadn't asserted these things within DMD. The basic summary is, because SNOMED International have changed the definition of the concepts we are linked to, we're in a bit of a mess. And we need to realign all our links to make sure we are linked to the contains only medicinal products, not the current contains some. This means updating the concept identifiers, the unique ID in DMD to new SNOMED concept identifiers. First pass analysis shows there are around 1,800 VTMs affected. Of these, we need to look at which ones will be assigned international contains only links. And if those don't exist, we will then assign new UK namespace codes. Enhancement 2, this is going to be the biggie for most people. This is looking at the next concept class down, the VMPs. Another concept class will be assigned international concept IDs where they are available, or we did. This enhancement is to shift to using UK namespace or extension IDs for all VMP concepts. Basically, any VMP that currently has an international concept ID, the short code, will get changed to having a UK namespace ID, the longer codes. As just explained for VTMs, SNOMED International has just changed their model and policy and now define VTMs and VMPs as contains only or contains some. They made a load of VMP changes in 2020 and 2021. And at that time, we had a lot of change to our VMP linkages. We had to update the concept ID for several hundred high volume, high usage VMPs in DMD. The impact was really destabilized, as you can imagine, for EPS, but we had no choice. It had to be done as we were linked to the wrong things in the international release because of their changes. But because we had to react, the disruption was really poorly managed, but we thought that was it, no more changes ahead, or so we thought. Another issue with our linkages has also now resurfaced, a change to the definition of dose form they use in the international release. In DMD, we assign the dispensed dose form to products such as amoxicillin suspension. We describe it as what the patient will receive. So we'll call amoxicillin suspension is what the patient will get when you get it from the pharmacy. Whereas in SNOMED, they use a manufactured dose form. So for amoxicillin, they would use powder for suspension. Another seemingly small change, but in medicine's terms, we're now talking about completely different concepts. We are seeing a pattern in seemingly small changes trickle through from the international release in the VMP layer, and each time we have to react. So instead of being reactive, we are going to have a one-off change in our policy. Currently, if an international concept exists, we use that concept ID for the VMPs in DMD. We will no longer do this. We will always assign an extension ID to VMPs in DMD and never change them to core codes. But more than this, we are also going to do a one-off change and give all VMPs extension IDs. Move is being done to shield DMD from further unplanned for changes as a result of international edition churn. This will be a one-off managed implementation of change, but will mean long-term stability, protection of DMD from any further instability created by international change. We'll do this in a managed fashion, proactively, roll out to our timescales, not having to react to international changes. Here you can see the current situation on the left-hand side, the alignment between DMD and the international edition of SNOMED CT. Orange is DMD, blue is the international release, purple the SNOMED UK drug extension. So DMD, VMPP, AMP, AMPP all align to the UK drug extension. They all have extension IDs. They align fully. VTMs and VMPs link to the international edition, medicinal product and clinical drug respectively. Where there is an MP and CD in the international release, we assign that international concept ID to the DMD concept, and this hooks DMD into SNOMED CT. On the right-hand side is what we're moving to, the insulated state, i.e. we insulate DMD from as much churn in the international edition as possible. Us taking control of the VMP layer allows us to insulate ourselves from any changes in SNOMED CT International. By assigning extension IDs to all of our VMPs, we're no longer reliant on what goes on with the clinical drug layer in the international release. We manage our own VMPs, we're insulated from any of the changes, and we then give ourselves long-term stability. We will still link to SNOMED at the medicinal product stroke VTM level, but no longer ever assign international IDs for VMPs. Yes, this will cause major disruption to EPS, to mappings. It will be painful, but it will be one-off. The payoff is that we manage this as a one-off change to ensure there are no more change ever in the VMP level, and that'll give us long-term stability. Interestingly, we're speaking to colleagues in South America recently. In Uruguay, they have a DMD type implementation, and they also link into SNOMED just as we do. They have also come to the same decision to remove all extension IDs from their VMP type layer, the exact same reasons. But let's talk numbers. We're looking at changing the identifiers of around 2,300 VMP concepts. We've run some analysis on the VMPs, and unfortunately, typically, there are some very high volume, high usage concepts in there. Two of the concepts, omeprazole and lansoprazole, for example, account for around 50 million prescription items through EPS per annum. All told, we're looking at changing the concept IDs and concepts that account for over 300 million prescription items per annum. Technically, this is a needed change for us to make in DMD. We can flip the concept IDs in a single release whenever, anytime, not a problem for us. But this is a change management project. We need to make sure that the systems can handle the changes and the EPS, for example, isn't going to crumble when we make the switch. So we're starting some major consultation, making sure that system suppliers know this is coming, understanding how they will handle it in their systems, and getting a grasp for how best we can roll it out. Big bang, make all the changes on release, or do a certain amount per release over several months. If you're a system supplier or a user who's got concerns, who hasn't been contacted, please drop us a line. We'd really like to speak to you. It should be noted that there have always been a current ID and a previous ID field in the VMP XML release for DMD. If suppliers have implemented this correctly, then the changes should be easily managed. They'll be able to pick up the previous ID and then actually technically move to the current ID with all the changes we've made. If the previous ID hasn't been implemented, we believe that's when people are going to run into problems. But we're going to do something else to help you as part of this, and that's something I'm going to come on to in Enhancement 8 in a little bit. Enhancement 3, a little bit more straightforward. Basically, the addition of trade family and trade family group to the DMD XML release files. On my first slide, I noted that the SNOMED drug extension contains an extra box, the 6th box, the trade family. It also has a link out to the trade family group that groups together trade names that have different active ingredients. The trade family is basically the brand equivalent of a VTM. The extra data is currently not available in the native DMD XML release though. To keep the data consistent across DMD and the drug extension, we're going to be adding the trade family and the trade family group to the authoring process for DMD and produce an extra XML file. This information is distributed with the native DMD XML release. As I said, we refer to the DMD model as the 5-box model. This is the SNOMED CT drug extension model. It's obviously not 5 boxes, it's 7 or rather 6 and a bit. We add in a trade family, which as you can see from the diagram is basically the brand name version of the VTM. And then we have the trade family group that, as you expect, groups together trade families. It is when there's an overarching name, such as Adalat shown here, and Caniston is always a good example as well. Caniston has experienced a brand explosion or potential exploitation. There's Caniston Canesten. There's Canesten AF, Canesten Thrush Duo, Canesten Hydrocortisone, Canesten Bifonazole, Canesten Thrush, etc. You can be talking clotrimazole, fluconazole, bifonazole, clotrimazole, and hydrocortisone. So if you record an allergy, for example, someone might say to you they're allergic to Canesten and they don't know anything else. So you can't recall the specific brand name and actually tell people that they're actually it's Canesten they're allergic to, so it's therefore clotrimazole. You can't make that assumption. So you have to actually have a level of abstraction above that, so you can actually record Canesten, and then that gives you multiple possibilities of what the patient may be allergic to. Anyway, trade planning group information is only currently available in the drug extension. We're going to also make it available in the core DMLD XML files. It will be a new XML file available in the bonus pack file, so users can take it if they want to, but it won't interfere with regular input routines if you don't want the extra information. Another addition we're going to be making is enhancement 4, the addition of ingredients to VTMs in DMD. In DMD, ingredients are authored for VMPs, but not currently for VTMs. VTM ingredient link information cannot be derived from any content currently within DMD. So why are we doing this? Well, at times a VTM can have an ingredient that is level of abstraction above the VMP ingredient. Think base versus salt, for example. As the information isn't derivable from any of the content, we're going to add ingredients to VTMs at time of authoring and make this information available in both the DMD XML and the drug extension. Just to give you a quick example, this is the representation for SNOMED, but the information you see here is for the products seen in DMD as well. You've got morphine 100 milligram MR capsules and morphine hydrochloride oral solution. The morphine 100 milligram MR capsules and also the tablets have an active ingredient of morphine sulfate, whereas the oral solution has an active ingredient of morphine hydrochloride. And that is given and has active ingredient link within SNOMED CT. It also has links within the DMD XML. The information we don't hold, however, is the ingredient at VTM level. And you'll see this example that the product containing morphine will have to have an active ingredient of morphine, because at that level you don't know what salt is actually available. So you have to give it a level of abstraction higher than the salts you've got. And I've got to put a note in here. We've talked about updates to the VTM class in Enhancement 1. There's no point doing any changes here until we've actually implemented the VTM changes per Enhancement 1. The next enhancement is the ability to positively identify and distinguish drugs, devices, foods, cosmetics, and any other category of product type. In DMD, the distinction between medicines and device, food, cosmetics, and so on is made based on licensing authority. However, clinically, intuitively, we sometimes need to classify them differently. I'll go straight into an example here because it's much easier to explain. In DMD, we take categorical information, no judgment calls. So when it comes to distinguishing between medicines and devices, for example, we do this purely on licensed information. Doesn't matter what we think it may be clinically, intuitively. If it's licensed as a device, it's a device in DMD. That's fine, it's categorical, it's correct. However, when we import the DMD information to SNOMED, we put the data into one of two hierarchies. Medicines go into the pharmaceutical biological product hierarchy, devices go into the physical object hierarchy. The problem with this is some things may be licensed as devices, but they don't intuitively look like devices. The example that often gets cited is synovial fluid injections. Because synovial fluid is a lubricant, it's not deemed a medicine. To be a medicine, something has to exert a pharmacological effect in the body. These are just lubricants, they don't. But it's an injection. I don't know about you, but if it's been injected into my joints, personally, I'd like to see it treated as a medicine in terms of decision support and warnings and so on. So in SNOMED, when we import it, we put this into the product hierarchy, so it's treated like a medicine. Whereas DMD would have it as a device because that's how it's licensed. The same is true for certain ear, nose drops, for example. They are also devices as per license information, so are devices in DMD. But in the drug extension, we'd say they are more medicine-like. But the import for the drug extension build can't pick these up automatically. We're always relying on human intervention. Enhancement 5 is therefore about automating this triage to get consistency, to improve quality, so we don't miss new products and incorrectly assign to the wrong hierarchy, and also to speed up the drug extension build. So NHSD are currently developing an input routine based on BNF categorization to automate this process. Enhancements 6 and 7, I'll briefly introduce them and I'll take them together to explain more about them. Enhancement 6 concerns stated parents for ingredients and modification of for DMD content of ingredients. DMD uses SNOMED CT substances as the ingredients assigned in the DMD model. These substances are currently a flat file with no association or links between them. NHS Digital is going to define a hierarchy for substances within the drug extension to enable correct classification of drug extension content, allowing better QA and automated build, and to support implementers in their use of ingredient content. Enhancement 7 is looking at stated parents for form and using unit of measure concept defined for DMD content. Again, DMD uses SNOMED CT forms and units of measure in the DMD model. Again, these are flat files with no associations or links inherent in each file. NHSD is going to define a hierarchy for form and unit of measure with a SNOMED CT UK drug extension to enable correct classification of the drug extension content, again allowing better QA and automated build, and to support implementers in their use of form and unit of measure content. I'm taking these last two together as they're related, just different hierarchies in SNOMED CT, but the principles are the same. Basically, in DMD, substance ingredients, units of measure, dose forms are flat files. There's no relationships, no associations, no parents, no information more than just a code and description, just flat files. I'm sure even with those who don't know much about SNOMED, just from the slides I've shown today, you can see that SNOMED isn't like that. It is not a flat file list. SNOMED is an ontology, a set of concepts and categories that show their properties and the relations between them. It's much, much more than a flat list. So these enhancements are about taking the DMD flat files and making hierarchies, adding relationships in the drug extension, applying the principles of the SNOMED CT international model. So if we use an example for substances, this is the slide I showed in the enhancement before. The VTM has an active ingredient of morphine. The associated VMPs have active ingredients of different salts. In DMD, however, there's no association between morphine and its salts. Obviously, to the eye, even if you're not clinical, you can see there's a relationship there between morphine, morphine sulfate, and morphine hydrochloride. But to a computer, they're just different codes, no relationship at all, can't do any reasoning on that. So these enhancements are about making those relationships in the drug extension files. For substances, this means stating parents, actually making the link between substances and what their groupers are. So morphine, morphine sulfate, and morphine hydrochloride all have the parents analgesic, central depressant, and morphine opioid. But morphine sulfate and morphine hydrochloride have the additional attribute they have an is modification of link to morphine. They're not children of morphine, they are modified versions of it. Building these links means that a computer can then reason knowing that morphine and its salts are linked because you've made that assertion for the computer. With units of measure and dose forms, we're just concerned with building the hierarchy and stating the parents rather than just having a flat file. These groupers again allow computational reasoning on data, analysis of all oral dosage forms, building of subsets based on dose form and so on. They can be automated rather than defining everything you want to go into a subset. By applying these hierarchy builds in the drug extension, this helps us automatically build the drug extension, run better QA, and also supports end users in data analysis and decision support. There's also another aspect in here, IDMP. IDMP, Identification of Medicinal Products, is currently just a suite of ISO standards that define how medicines terminology for regulatory purposes should be built, but is beginning to be implemented by the EMA. They are currently updating their internal database, the Article 57 database, to these standards. As with DMD, it's not just about having cool boxes. In IDMP speak, they have the MPID and the PHPID, very much akin to the VMP and AMP, and they also have associated standards. So the standards ISO 11238 11239, and 11240 define substances, dose forms, and unit of measure. How these are represented in SNOMED will map into IDMP. So by following this SNOMED route, then we are future-proofing ourselves for the advent of IDMP. But why is IDMP important? IDMP is going to be implemented by the MHRA, and it's also going to form the basis of the language to support medicines transfer for International Patient Summary, or IPS, which our Secretary of State for Health has made a commitment to support at the last G7 Health Summit. Enhancement 8. This is the one I noted in Enhancement 2 as a support for the implementation of the VMP changes. For core concepts in DM&D, such as BTM, VMP, ingredient, etc., DM&D has fields for current and previous ID, so that any changes can be communicated in the XML release. But it only holds the current and one previous. No other historic ID data is held in the XML release files. Enhancement 8 is to produce a new file in the XML release that has all historic codes, not just the one previous. The key reason for this is we need to support system suppliers and legacy records with the changes that are coming through with the updates of BTM and VMP codes. The previous ID field was put in support times when an extension ID was given to a BTM or VMP, for example. So an extension ID was given when it was authored because no international release ID existed. When one became available, when that product became available internationally, then the ID would be updated to an international ID. So there are already some VTMs and VMPs which will already have the current and previous fields full. When we roll out these new enhancements for 1 and 2 and make these changes to the concept identifiers, the previous ID currently in the XML will fall off the end. We need to actually therefore have this file to support implementers and make sure the data continues to be available. The XML file will be available as an extra file to download if you want it. We're hoping with a fair wind to release this by the end of the year. We will also most definitely be going to get the data into the terminology server, but that won't be by the end of the year. That's timetabled in for next year, but yes, it is intended that it will definitely go into the terminology server at some point in the future. Enhancement 9. The current model used for the drug extension was defined over 15 years ago at a time when there was no international guidance from SNOMED International or other member countries. It was therefore a UK bespoke model, and it is actually to meet the needs of the time. In defining the model, there were limitations, not only due to the SNOMED International model at the time, but also their release format, or release format 1, RF1 as we called it. The international model definition, guidance and release formats have now been updated. We've got a release format 2, and it can handle a lot more things that we couldn't do back when we were in RF1 days. And so now making an update to the UK drug extension is quite timely. We're therefore going to uplift the SNOMED CT UK drug extension to align with the SNOMED International model for national drug extensions. The main reason for doing this: the original DM&D principle for international interoperability was allocation of international edition concept IDs for VTM and VMP, as well as other supporting information such as ingredients and substances. If this would then allow international interoperability with implementations of VTM and VMP content in other member nations, we exchange codes, we understand them, irrespective of what language the text was written in. However, a couple of things. First off, we intend to get rid of our links to the international edition for our VMPs enhancement 2. And fundamentally, the reality is that poor level of implementation of the VMP layer across other SNOMED member countries has meant the original vision of having interoperability through shared VMP content was never achievable anyway. As I said earlier on, Uruguay, they were using the international IDs for the VMPs. They are now moving away from that to extension IDs as well. So regardless of whether we keep VMP links, we need a new approach to international interoperability. By implementing the SNOMED international model for national extensions, we're looking to add in internationally understood relationships to our content. We define them, and by doing so, we can understand any concept that comes into us. If they have the same defining relationships as defined within SNOMED, we can check equivalence across national extensions. Again, we have to think about potential future alignment to IDMP. The assumption is that SNOMED CT will continue to align, and we will have to map into IDMP if we're going to play in the EU International Patient Summary space. So following the SNOMED model will give us a head start on that. And basically, as I said in the start, the current model is outdated. It's time to move on and time to do it better. This, of course, builds on the work of Enhancement 4, addition of ingredients to VTMs, and Enhancement 6 and 7 around substance, unit measure, and form. And finally, Enhancement 10. Create a frequent data exchange between NHS BSA and NHSD to support processing and producing near synchronous releases of DMD and the drug extension. This is the enhancement previously known as Fluffy Cloud. I've talked through all the wonderful things we're doing in order to align the data content and the two terminologies. But if you remember from the start, data content was only one of the issues. The other issue was around release timings. We are aiming for contemporaneous and synchronous releases. The enhancements I've talked about will only get us so far. They'll sort out the issues in terms of data, but only get us so far in terms of time lag. We're only partway there. They do not allow us to produce the releases simultaneously. Yes, and the enhancements do help in terms of allow us to automate some of the current manual processes, but at the end of the day, NHSD is still waiting for the BSA to send them the weekly DMD XML before we can start on the drug extension build. So at the moment, the NHSD gets sight of the DMD data when we get sent the files to put on TRUD. The BSA get the SNOMED International updates every 6 months. If we're going to reduce time lag, this isn't good enough. The grey shows the BSA. They work on the DMD database. They send us files each week, and we load them onto TRUD and also into our authoring tool, SNOEL, for us then to start on our drug extension build. And every 4 weeks, we squeeze out a release and then put that onto TRUD. What we are saying is instead of waiting for the BSA to send us files each week, we have a bi-directional feed, a daily exchange of data between the DMD tool and the SNOMED SNOEL tool. So we're working on updated data. This feed means we can get the time lag of between the last DMD release and the drug extension going out down to a couple of days. So we'll be releasing in the same week rather than a couple of weeks later. Is it doable? We've found nothing to this point that's telling us it's a showstopper, but we're still in the process of defining an exact solution. So that's why we're still on the working title of Fluffy Cloud. We're not quite sure what that means in the middle, what we're actually going to put into that as our solution. So that in a rather long nutshell are the 10 enhancements we have planned for DMD and the SNOMED CT drug extension in the short to medium term. Some majorly impactful on end users, some just for our internal workings. One of the key questions I'm sure I'm going to get asked is around timescales. As you can imagine, this is a rather large project. A lot of change for us to accommodate across two organisations. There's also an awful lot of engagement we need to do before we can confirm our rollout plans. As I said earlier, we can't go live with something like Enhancement 2, the change to the IDs for the VMPs, until we've engaged with all system suppliers and users to make sure they can support the changes, and we need to get our plans right for rollout. We're very much in the planning stage at the moment, and apart from Enhancement 8, the historic code, which, as I said, we intend to roll out before the end of the year, we don't currently have any timescales, but we will communicate them as soon as we have them. We're cognizant there's a lot of change, so comms is key. As soon as we have something confirmed, we will let you know. The enhancements are approved. They're going ahead. So we're communicating them now to let people know they're coming. The timescales will be the next thing that we tell you. Again, major apologies that I couldn't be here in person today. I will try to get to Learnathon for the end of this pre-record to answer any questions. If I don't make it, then please do get in touch. We have an email address for the programme specifically set up for these enhancements and to talk about anything, any concerns, and that's ukmeds@nhs.net. That should be going live by the end of this week. If you can't wait for that to go live and you need to get in touch, please just drop me a line directly to joe.goulding@nhs.net. Thank you for your attention, and hopefully we'll speak later.
Okay, so I'll stop sharing. I think Joe's on a call, and apologies to you, Joe. I was sharing my screen, so I couldn't see that you were in the waiting room. So my sincere apologies. I was also not tracking the chat. Are there any questions in the chat? I can see, Joe, you've been responding to some of them.
I think there's one that was missed because obviously you only pick up the chat from when you joined. So Jeremy asked a question earlier on, and I'm not going to read out the numbers, but Dan, I don't know if you can copy the one from 318 back in. Both MyGleaf Pink and Uniflow were already direct child codes of cocodamol as far back as January 2006. SNOMED hasn't changed the definition. They've made it clearer what it always was. They didn't have a method to represent this and nothing else, but until relatively recently, so that only the possibly something else to form was ever supported. Oh, I should have breathed in that sentence.
Thanks for that. I will
copy it back down. I don't have the rights to do it. Yeah, that's it. Thank you. So it's in the chat now, Joe. You're on mute.
I don't think there's anything to answer, it's just a comment from, there's no question there that I can see, unless Jeremy wants to pose a direct question. I thought it was just a comment for clarification.
It's just a comment for clarification.
Yeah.
Okay. Thank you, Jeremy. Any other questions for Joe? So, well, if you do think of any questions, Joe's obviously shared the emails in her slides, and we'll share those slides at the end of the meeting, or once we have the recordings ready. So all those links will be out. So please feel free to get in touch with Joe. If there are no other questions, then we will finish this. Well, we'll finish this session, not the meeting. So
I suppose I could. Can I? Sorry, I just thought of one, just to give Joe something to talk about. So, given that your example, so this is playing devil's advocate, has been out in the wild for not quite 20 years without any obvious harm, are there other examples that are perhaps more of a clinical safety risk that warrant the movement of all of the VMP, whichever it is, codes within DM and D to something else? Are there cases where the mismatch between currently pointing at a VMP, which we thought meant it contains these ingredients and nothing else, but actually has always subsumed in the SNOMED side of the drug extension, has always had underneath it products that contain the ingredients of the VMP, plus possibly other things as well? That's always been the case, I think. And so nothing's broken, as far as we know, in 20 years, or has it? So are we doing this grand shake-up of the identifiers with good reason, or just because it's always better to be fully aligned than not?
I don't have a better result off the top of my head, so I'll have to go back to the hierarchy and have a look at it for you. I don't carry them around in my back pocket, unfortunately, but I can definitely pull some out. That was a little bit of a maybe misdirect, because all the work to realign between contains some and contains only for VMPs has already been done. We did that last year and the year before. We made quite a few changes, and that's what disrupted EPS. I think it made 167 changes. I think Kerry might correct the numbers. But it made quite a few changes last year, and it virtually broke EPS, which is why we need to tread carefully this one this time. The reason we're doing the VMP changes is because they've now looking at definitions of dose forms and looking at the fact that we use what we give to the patient, the dispensed dose form, whereas they now use the manufactured dose form, and those differ things like oral suspensions. So they're changing what they use VMPs again. So that's another thing we've got to change to actually align with that. So we're just waiting for the next thing to happen to actually say, okay, so what are you going to change next? And we have to do some more changes. And it is just literally a line in the sand, Jeremy, to say we can't keep doing this reactive churn. We don't know what's coming. SNOMED International don't tell us what's coming, and they just keep make changes to the content we are aligned to, and it disrupts us every single time. So this is we want to do it in a managed fashion. And so that is why I've taken the decision that it's a hard line, but we can't keep taking these knocks that are being enforced on us. So we have to be proactive and actually protect our asses really
the future.
Thanks.
Thanks both. Final opportunity for any questions. If not, we will move on to the next session. So but just before that, thank you, Joe, for the video and for making time to answer the questions. Really appreciate that. But just before I move on to the next session, which is the wrap up and also setting scene for the hackathon, I'd just like to thank everyone for, especially presenters, for coming and presenting the items, for everyone for attending, and also special thanks to Jasmine and Georgina for their help, and also to Chris as well for all the support. So with that, I will just pass on to Chris for the wrap up. Thanks all.
Thanks, Dan. Isn't that my job?
It is. Well, I just wanted to thank everyone as well.
Here we go. Let's see if I can share my screen. Is that on screen okay?
Yeah.
I might need to look this way a little bit. Apologies, folks. It's not on the screen I want it to be. Okay, so thank you, Daniel, and thanks everyone for joining today. Just a quick recap around the day. Obviously, we set the scene this morning with some of the things that we're going to talk about, and being joined by a lot of people today, and we've moved through this middle section to me talking about the hackathon and what we intend to do next. And I won't take too long to do that. Hopefully, what we've talked about today has whet your appetite anyway, and you were here for a reason to think about the hack. So the hack is going to be on the 18th and 19th of October. As I say, a little closer than we would normally do it, but these were the original dates that we set, and we didn't want to shift back further, what with the time of year and things getting busier. So so 18th and 19th, we would like to invite you to join us again, virtually. We were hoping to get a live hack in this year. We kind of had a small one at Digital Health Rewired, where we joined the social care hack, which was really good to get people back together in a room doing things. But maybe next year for that one. This year we are virtual again on those dates. We've tried to take a slightly different tact with this one. The hacks previously have been, although we've done things at them and taken things away from them, been very focused on sharing education further and sort of teasing how some of the workflows might look using the fire standards, etc. This time, we really want to drive things forward. We're at a level of maturity now with the standards, with the ISN, that we know that system suppliers are out there and working with them to develop against them. And that trusts have got a keen interest in getting that moving forward quickly. So we plan to accelerate the development of the real standards, the standards that support and deliver the workflows. The Interoperable Medicine Standards Programme is kind of central to developing these standards, but actually the implementation falls into APIs and guidance that is delivered through other programs within NHS Digital and wider. So what we want to do is to work with them to uplift their guidance, to make sure that dose is embedded into it, so that the right information is out there for suppliers to be able to build the interfaces. So we will be working on our previous learnings and taking things forward from there. And we will keep the form of the presentations on the second day, and the winning hack teams having the opportunity to come back a few weeks later and to show what they've done to the NHS Transformation Directorate team. So there is that opportunity, and there'll be two votes. There'll be the team that's the choice, the votes from the participants. And we'll also have the CTO office there, so the Chief Technology Officer for NHS England, so CTO's choice. So both of those will get an opportunity to take forward. And last time we did actually showcase some other bits and pieces there as well. So we'll make the best opportunity of showing the work and how it's progressing to that senior team. So it's a little bit of an incentive there, but certainly worthwhile, and gives us the opportunity to show just the effort that goes into these and what can come out of it. So the things that we'll be covering. So transfers of care, so introducing structured dose. We've dabbled with this a little bit with GP Connect last year and dropping dose into their STU3 guidance. We'll be back with more test data and a test system to do that with, but equally we're going to be trying to crack that with the UK core guidance as well. So that will be the structured, the direct care API as it's now called, teams structured Medicaid or get record structured API in both STU3 and UK core. And the intention for that is that at the moment, the implementation guidance for our work shows how to do dose, but that needs to be embedded into these other standards that are published on the API catalogue for people to be able to really interact with them and see this is the real piece that is expected. So they'll be there supporting us. So Direct Care API team are in there. We're also working closely with the IOPS team, as we mentioned earlier, and we'll be looking at the other end of that journey. So the transfer of care standard, which is currently published STU3, again without dose, and that's the standard for discharge at the moment. So we'll be looking to drop that in and to uplift that, playing with both STU3 and UK core. But also what we want to try and explore further with that one is a change to the delivery mechanism, because currently that's over mesh. We want to explore what that might look like over HTTP as well, so RESTful transfer of care. The medicines reconciliation theme flows from that, really, that those standards enable medicines reconciliation, and we've certainly seen some of that in the past. Both meds on admission, meds on discharge back into GP system is the aim, but equally how that would be surfaced as part of a shared care record. So we're keeping that shared care record theme moving. As we've seen today, PRSB are joining us and want to see how they can map and align with FHIR to the standard that they've got. So looking at those insulin regimes on admission and discharge, which fits with the previous themes, and in shared record, and equally the insulin pump information. So there's quite a lot going on in that space, and as I said, I think it'll be a really interesting addition. The terminology server will be there again. We've got additional things starting to happen with the terminology server, certainly more interest, and so some of the things that the workflows that Bill demonstrated earlier that could be delivered through the terminology server, we'll certainly be exploring. And I think there was some conversation equally on that call around concept matching and doing that at scale. And so we've definitely got interest from some vendors who have been on the planning calls and looking to move that forward. So there will be more about the UK terminologies products. We hope to use some of our team to feed into that, and certainly if there's an opportunity for us to delve into more depth around what some of that might mean out into service in the future as we start to get closer to our delivery plan, there will be some workshopping around that, and developing the UK core resources. So as I said, IOPS team, Dave mentioned earlier, are also looking to do a hackathon in their own rights. What we're hoping to do is through some of this more advanced work that we're looking at, to identify where other areas of FHIR that haven't yet been defined to the same level might be needed to support the message flows, to give that extra detail and wrap it around just the meds and the patient, to give a fuller picture. So they're kind of the core themes, but really the themes evolve through the planning calls. We've only got a couple left, and I'll come back onto those in just a second. So there's a lot going on, but the only way we're going to do it is through collaboration. And so as a team, we've got our Interoperable Med Standards team, and we'll obviously be bringing along the resources that you've seen today talking to you. So our product implementation and relationship management, user-centered design, our clinical safety experts, and the technical terminology specialists. There will be terminology server expertise. I've mentioned Direct Care APIs team will be sending some developers along and are standing up some information test data for us already. IOPS will be supporting us, PRSB, but equally it's getting the community, the suppliers, system suppliers and developers on board, and the trusts. It's really helpful when we get system managers and leads on who can give us a real world perspective on some of the challenges that they see, because it just helps get that information back into the right space and looking at the workflows in a real term. So certainly we would encourage people to join us. The registration link we'll share as a link anyway. This presentation will be shared and we'll put that in there. And equally, as I said, if you do want to join the planning calls, get an email out to secretary@interopen.org. We'll be there bright and early tomorrow morning with a cup of tea and a biscuit to wake ourselves up, and starting to work through some of the output from today and what we've started so far to make it a hack worth attending. And that really brings me to a close, and some thank yous that Daniel's already done well for me, but certainly to all of the presenters, to the people who've helped us organise this, thank you for your time, both in preparation and on the day. I think we've had a successful day with a lot of information shared, which is really great. Obviously the organisation, Daniel's mentioned Georgina and Jasmine, but certainly Daniel has put a huge amount of effort into this, and so thank you, Daniel. It wouldn't have been the event that it was without you. So I'm going to finish there. If anybody does have any questions, I'll stay online for just a couple of minutes, and then hopefully we'll see you either tomorrow morning or at the Hack in a few weeks' time. Thank you very much.
Thanks, Chris.
You're still on mute.
I'm not.
But I can't hear you.
Okay.
Ah, you're here now. You're caught up.
Okay. Yeah, I've just put the link in the chat, registration link. And yeah, I will also put into Secretariat's email address so you can contact them.
Thank you. Thanks, Dave.